هي إحدى خريجات كلية الطب جامعة صنعاء، حاصلة على الدفعة الأولى نعم المركز الثاني، وأخذت البورد الأردني في 96، ثم دبل بورد الباطنة والاندوكراين من أمريكا، وعادت للوطن محبة بالوطن، وهي الآن يعني تقدم الكثير لمرضاها. عنوان المحاضرة 2024 Update to Management of Type 2 Diabetes ADA Guidelines، يعني American Diabetic Association Guidelines. فلتفضل الدكتورة مشكورة.
السلام عليكم. Okay. Can you hear me? Okay. Hello, can you hear me? Okay. So today I'll be giving you an update on the management of type 2 diabetes, and I try to concentrate mainly on the new things. And there are some things that you've probably heard them in the past, because some things change in diabetes and some things don't change. So how should we start screening for type 2 diabetes? First of all, before a few years we used to say everybody above the age of 45. Now we say everybody above the age of 35. Okay, and who else should we screen? Patients with a history. Okay, patients with a history of gestational diabetes. Also patients with a history of pre-diabetes. Also patients who have taken high dose of steroids or have a history of pancreatitis or have HIV. Other patients that we should start screening, anybody above the age of 18 who is overweight or obese and has an additional risk factor, like they have a first-degree relative that has type 2 diabetes, they're inactive, they have cardiovascular disease, hypertension, females with a history of polycystic ovarian syndrome, hypertriglyceridemia. All of these are factors that make us start thinking and looking at this patient and saying, maybe I should screen them for type 2 diabetes. What are the tests that we should do? I'm going to start on the left-hand side with fasting plasma glucose. We all know the fasting plasma glucose, the normal level is less than 100. 100 to 125 is pre-diabetes. 126 and above is diabetes. Also, we can, if the patient has a lot of symptoms and you do a random blood sugar and the random blood sugar is above 200, that's also suggestive that this patient has type 2 diabetes. The gold standard that we always say is the gold standard is to do a 2-hour glucose tolerance test. And we give the patient 75 grams of glucose, check their blood sugars 2 hours later. If it's above 200, this patient has diabetes. If it's between 140 and 200, this patient is pre-diabetic. And if it's less than 140, then this patient normal. وبعدين نجي HbA1c. Okay? The normal HbA1c is less than 5.7. 5.7 to 6.4 is considered pre-diabetes. And greater than or equal 6.5 is diabetes. بس حاجة مهمة جدا. If you're going to use the HbA1c, it has to be standardized. فما ينفعش عندنا to use the HbA1c and tell the patient you are diabetic and you don't do the blood sugar. وهذه بتحصل كثير جدا. We see patients, at least one patient a day, that was told he is diabetic just from an HbA1c that's 6.2, 6.3, 6.5, and nobody checked the blood sugar, and they start them on treatment and tell them, okay, and بداية سكر، مؤهل للسكر، مش عارف إيش من كلمات. And the blood sugar was never checked. لو تأخذ نفس السامبل، وقد قلت لكم هذه أكثر من مرة, to several labs, the same blood sample, everybody will give you a different HbA1c. That means it's not standardized test. That means you cannot depend on it alone to diagnose diabetes. لازم يكون معك blood sugar. وأنصح أول شيء افحصوا blood sugar. If it's abnormal, then do the further tests. Okay, don't do the HbA1c. Tell the patient he's diabetic, and patients are started on treatment without ever checking the blood sugar. This is not proper management. Okay, so even in the guidelines, they say the test has to be standardized to use it to diagnose diabetes. Okay, عندنا احنا it's not standardized. لو رحت أحسن المختبرات, everyone will give you a different number. And also the A1C can sometimes trick you. The patient may have diabetes, but he's anemic, or he has renal failure, or he has a female that is pregnant, and the HbA1c will be normal or low. So there are diseases that will cause a low HbA1c. So again, you cannot depend on it alone to diagnose diabetes. So what's new in diagnosing or screening for diabetes? A few months ago, the International Diabetes Federation started talking about the 1-hour glucose tolerance test and said it can be used for screening of patients for type 2 diabetes. ليش the 1-hour test? ليش ما نستمرش على 2-hour test? Because they said that the studies have shown that the 1-hour test is more sensitive and will start increasing years maybe before the 2-hour test starts becoming high and we diagnose diabetes. So if you check the fasting blood sugar, maybe it's still normal. You check the 2-hour, maybe he's in the pre-diabetic range or normal. But if you see the 1-hour test, you will see there's always a peak after 1 hour. So what they say is the normal test for the 1-hour glucose tolerance test for the normal is less than 155. From 155 to 209, this is what they called intermediate hyperglycemia, what we used to call pre-diabetes. So already we're going toward diabetes. And 209 and above, this is diabetes. And for those of you that order glucose tolerance tests, we always used to look at the 2-hour. But if you looked at the 1 hour, it would jump up and then go down. So if you use the 1-hour test, you're going to diagnose many more patients with diabetes earlier, and you're going to diagnose many more patients with pre-diabetes. Okay, so they say you can prevent the complications of diabetes, you can prevent diabetes if you use the 1-hour test. It's more effective than the 2-hour test, and you'll diagnose patients earlier. But so far, it's only the International Diabetes Federation. It was not included in the American Diabetes Association guidelines from last year. I don't know if they'll have it in the guidelines that will come out next month. We'll see. So how can we prevent diabetes? We always try to say pre-diabetes. What can we do for this patient if he's diagnosed in the pre-diabetic stage? Okay, so first of all, they want lifestyle behavior change. That's the most important part to prevent diabetes. And if the patient is overweight or obese, we try to make them lose 7% of their body weight. And usually they admit these patients to an intensive program. Unfortunately, we don't have these intensive programs. They have to see dietitians and so on weekly and exercise and so on and try to lose 7% of their body weight. And they have to do at least 150 minutes of exercise per week. That means about 30 minutes a day, 5 days a week. And there are different diets that they can follow to help them lose the body weight. We want them to follow a healthy diet plan. It's not one size fits all. Maybe this patient in this area, this is the food that's available for them. And this patient in another area, there's a different food that's available for them. So the dietitian really has to sit with the patient, see what kind of food they have available at home, what are the foods they can afford, because we are in a poor country. Maybe most of the patients, they're eating just carbohydrates. Very rarely will they have protein in their diet or meat in their diet or so on. So it has to be between the dietitian and the patient, see what he eats, what he can afford to eat, because it's not going to be any use to write a bunch of expensive things for the patient that he cannot afford to eat. And again, convince them to exercise, whatever exercise they can do. Even in older patients or so on, just getting up at home and moving also helps prevent progression to diabetes. And then who are the patients that we're going to consider starting on treatment? We say lifestyle intervention, and then we also have metformin, which we can use to prevent diabetes. Will we put everybody on the metformin? No. We usually try to emphasize the need of lifestyle intervention. But who are we going to maybe start metformin from the beginning? If the patient has a BMI greater than 35, if the patient has higher blood sugar levels, like for example, his fasting blood sugar is not 104, 105, he's already running 120. That means he's pretty close to becoming diabetic. Those are the patients that I'm not going to wait for the lifestyle intervention. Advise them and give them the metformin. Also, if the patient has history of gestational diabetes in the past, and she has become now pre-diabetic, then we probably should start her on metformin. And like we said, we should start metformin if the patients have a high BMI, history of gestational diabetes, higher blood sugar levels. Those are the patients that you probably want to start when you first see them on metformin. And also we should emphasize on smoking cessation, because smoking is bad for everything. It's not something good. So how should we follow up our patients with type 2 diabetes? We should check the HbA1c at least 2 times a year if the patient is under good control. If the patient is not controlled, then we should usually see the patient every 3 to 4 months. And what is our goal? For most patients, we can say the goal of an HbA1c of less than 7 is okay for most patients. If the patient is young and we can reach a goal of less than 7%, an HbA1c less than 7%, then that's fine without making the patient hypoglycemic. Also, if the patient is old or has a limited life expectancy, for example, the patient has terminal cancer or has some other chronic disease that we expect he will die soon from, then there's no need to keep checking the blood sugars 10 times a day and putting the patient on many medications or so on. An HbA1c less than 8 is reasonable. An important thing that they mentioned in these most recent guidelines is fatty liver. That non-alcoholic fatty liver is present in about 70% of patients with type 2 diabetes. And there are medications, some of our medications, oral medications that we use for type 2 diabetes that are effective in lowering the liver enzymes in these patients with fatty liver. Weight loss is the most important with intensive lifestyle. Also, thiazolidinediones, pioglitazone, is very good in reducing the fatty liver. And also GLP-1 agonists. They advise to use these if you have fatty liver. There are also studies that have shown that SGLT2 inhibitors lower the liver enzymes in patients with fatty liver. But it's not added to the guidelines yet. But I've seen patients that I put them on SGLT2 inhibitors, and then a few weeks later we checked the liver enzymes and we found that they've come down. But if you have elevated liver enzymes and so on and the patient is not improving, you should refer them to a gastroenterologist. And then we have diabetes self-management, education, and support. So it's very important that our patients be educated about their disease. Many of our patients are illiterate. You give them a medication, they think it's just one box, and then they stop it. Even if you tell, they're surprised. You mean I have to continue with this? And so they have to be educated about their disease. What are the complications of diabetes? What are the dangers of stopping their medication? How to follow diet? How to exercise? How frequently should they follow the doctor? When should they see an ophthalmologist to get their eyes checked? And so on. So this is a very important program. Unfortunately, we don't have enough diabetes educators here. That a patient goes and he learns about his disease. يعني مش معقول كل ما طلع السكر عندي 200 نزل السكر عندي 50 ايش اسوي يا دكتور? If they go to this program, they should, when they finish this program, they should be educated and know how to manage most things on their own. So it's a very important program, and inshallah we will have soon diabetes educators that we can rely on, and we can send the patient to them. Because the doctor does not have time to keep explaining all the disease وكذا. And then the patient goes online وبيتوه. واحد يقول له كل بامية، واحد يقول له مش عارف إيش، واحد يقول له تمام. They don't know what is right and what is wrong. Again, also patients with type 2 diabetes, we want to advise them to try and lose 5% of their body weight, and they really have they have a very good improvement in their blood sugars if they do manage to lose the weight. And you have to motivate the patient. Not all patients are the same. Some patients become motivated in the beginning, and then a few weeks later they get tired and they stop. So the patient has to be continuously motivated to follow diet, to exercise, to be careful with what they eat. And the medical nutrition therapy, like we said, it's not one size fits all. Everybody is different. What I might tell this patient is different, but the general idea is the same. You have to eat a healthy diet. You have to try and avoid processed food and sweetened beverages and so on, and try more with normal vegetables and low carb diets and so on. Okay, so most of our patients with type 2 diabetes are overweight or obese. And if you have a patient that is overweight or obese and you're going to treat them for type 2 diabetes, you want to try and concentrate on medications that help with the weight loss. So you don't want to give them something that's going to have them gain weight. And if you give them a medication that, obesity medication that we have, some of them for type 2 diabetes, some of them just for the management of diabetes, if they don't manage to lose 5% of their body weight in 3 months, then probably this medication has to be changed or the dose has to be changed and so on. And maybe also these patients are someone that we might consider referring for metabolic surgery if they're very obese and they have a lot of complications from their obesity. Then metabolic surgery is a good idea for these patients. And even in patients that are not overweight or obese and have type 2 diabetes with complications, then also maybe we can consider metabolic surgery in some of them. So now we're going to talk about, in general, medications that we use for treatment of type 2 diabetes. So these are the latest guidelines that we have. Okay, so I know it's a very busy slide. So if you look on the left-hand side, first of all, on the top, they say healthy lifestyle for all patients. We have to emphasize that the patient has to change their lifestyle, their diet, exercise, and so on. Then they divided the patients to patients with... Can I remove this? أيوة. This isn't too. Okay. Well, let's see. Okay, so if we start with on the left-hand side, patients that have established atherosclerotic cardiovascular disease, or patients that are high risk for atherosclerotic cardiovascular disease. The treatment of choice in these patients are GLP-1 agonists. Okay, we don't have them readily available. Some patients come from outside using them. There are some pharmacies that have a limited amount available. The problem with these medications is that they're very expensive. Not all our patients can avoid them. But they are the best medication to decrease the risk of developing recurrent heart attacks. If we don't have GLP-1 receptor agonists, we can use SGLT2 inhibitors, which are also effective in decreasing the risk of recurrent cardiovascular disease. If one of them alone does not control the diabetes, then we can use both of them together. We can use a GLP-1 agonist and an SGLT2 inhibitor. And then again, they say also if these patients are high risk or have recurrent stroke or so on, then we can add a thiazolidinedione, which also decreases the risk of recurrent strokes. And also, if you don't have these medications, or you're on 2 medications and still not controlled, you can always add any of the other medications like metformin or any other medications as the doctor sees as needed. Then we come to patients with heart failure. As you all know, I am sure all the cardiologists now are using it just to treat heart failure, even in patients that are not diabetic. So if you have heart failure and you have type 2 diabetes, you want to put an SGLT2 inhibitor treatment for these patients. If they tolerate it, then that's fine. If the patients are controlled on it alone, that's fine. If not, you add other agents, again, as needed. And then we come to the patients with chronic kidney disease. Either they have just diabetic nephropathy and they're starting to have proteinuria. SGLT2 inhibitors are very effective in reducing the proteinuria. Also, if the patients are starting to have decreased creatinine clearance and going into renal failure, you can use the SGLT2 inhibitors up to dialysis till the creatinine clearance is less than up 20%. So even if the patient already has a creatinine 4 or 5 and so on, patients still not on dialysis, you can continue to use the SGLT2 inhibitor. And many studies have shown that it delays the onset of dialysis or the need for kidney transplant. And also, it has also been approved, these medications, for treatment of patients with renal impairment, even if they're not diabetics. So now we have nephrologists using them, and the cardiologists and the diabetologists. Okay? An important thing, if a patient comes to you and he has other medical problems like heart failure or ischemic heart disease, make sure you look at the medications, because you might end up giving the patient 2 SGLT2 inhibitors or double the dose that the patient needs to take. Because maybe the cardiologist wrote the medication for him as a cardiology medication, as a heart medication, and then we come and write it as a diabetes medication, and we didn't look at the other treatments that the patient is on. So it's very important. The patient doesn't know. He says, yeah, I'm on heart medications, but he doesn't know that this medication is also for diabetes. So I think you have to always make sure you look at all the patient's medications. And then, of course, if you're on a SGLT2 inhibitor and still not controlled, then you add on other medications, either oral or insulin, as needed. Then we come to the other patients, the patients that we want to control. You can use metformin plus any other agent combination, depending on what you see appropriate. And the patient is overweight or obese, we want to concentrate on medications that help with weight loss, and if not possible, giving a GLP-1 agonist because of the price or not tolerated or so on, then at least give medications that are weight neutral, like a DPP-4 inhibitor and metformin. They won't cause any weight gain, but might help with the weight loss. And then other thiazolidine, we still use thiazolidinediones. I know they cause weight gain. I know they cause fluid retention in patients with heart failure. If you choose your patients properly, they're a very effective medication. They're present in all the guidelines, the European guidelines, the American guidelines, and so on. So they're still a good medication to use if the patient is not in heart failure, does not have kidney failure, does not have fluid retention, and is not very obese. Because if they're obese, they gain weight very quickly. So this is sort of a summary. I know there are other lectures today and tomorrow giving on the different groups and giving you more detail. And of course, if you're not controlled on oral agents, you want to start insulin. But when will we start insulin? From the beginning. So let's look at this patient. This is a 45-year-old obese man who was with his friends, and they were checking their blood sugars on a glucometer, and he was found to have a blood sugar of 500. He has been having polyuria, polydipsia for some time, but ignored it. So he didn't know he was diabetic until he did this aqua check. Then he went to have his HbA1 checked, and it was 14. His other blood work was normal. So he comes to your clinic for further management. So what treatment would you start him on? How many will admit him to the hospital and start insulin? Let me see. Anybody will admit him to the hospital? Okay. Start insulin in the outpatient setting? How many? Nobody? Okay. Start oral hypoglycemic agents? Okay, a few more. Nobody is reacting? Okay. Advise diet and exercise and repeat blood sugars in a few weeks? Dr. Mohammed Bamishmus would start insulin. That's fine. I would start oral agents because he's clinic. Huh? And go to insulin.
هو نزل يده.
Okay.
نزلها.
The patient is very stable, although his blood sugars are high and the HbA1c is high. He pretty much was asymptomatic until they checked his blood sugar. So starting oral agents is okay, and see what happens. Follow him up, see what happens to his blood sugars, and so on. So he doesn't need admission to the hospital, because I often see patients coming, they said, oh, my blood sugar was 500, and I was admitted to the hospital. And they said they were in good condition. So there's no need. Admitted to the hospital. Yeah, so you can just start them outpatient. There's no need to admit them to the hospital. This is the last slide.
شكرا.
Okay. Unless they are decompensated, dehydrated, losing weight, and so on, you can start insulin. I would leave admission to the hospital if the patient is metabolically unstable and starting to show signs of dehydration, maybe elevated creatinine and so on, needs fluids and so on. Those are the patients that would need admission to the hospital. Otherwise, you can usually treat them outpatient. And I would start a patient like this, stable, in good condition, on oral agents. And thank you very much. I'll stop.
شكرا جزيلا للأستاذة الدكتورة بثينة الشرفي على المعلومات القيمة، ونتمنى أن تكون هذه المعلومات مطبقة في المستشفيات. كثير من الكوادر هذه out of hospitals مع الأسف، يعني نتمنى أن يكون لهم ظل في المستشفيات الحكومية الخاصة. طبعا هذه حاجة ثانية. فالآن آخر محاضر بيقدمه الأستاذ زايد.
آخر المتحدثين في السيشن هذا الدكتور هاني مباركوت. الدكتور هاني مباركوت. الدسكشن في نهاية السيشن، ومعذرة لأنه يا أعزاء يعني أخذنا الوقت كثير، لأنه قد أخذنا من الوقت الآن من البريك. فالدكتور هاني مباركوت من أنشط الكوادر اليمنية، هو رئيس الرابطة الحضرمية لمكافحة السكر في حضرموت، خريج جامعة حضرموت، و post graduated and got his training in Egypt في جامعة أسوان. من الناس النشيطين جدا وله مستقبل طيب، و من أسيوط عفوا. أيوة. والدكتور هاني أكيد
صباح الخير دكتور زايد، هل تسمعني؟
نعم أسمعك يا دكتور.
أسعد الله صباحك، وأنا شاكر لها الكريمة من الجمعية اليمنية ومن حضرتك ومن الأساتذة الكرام ومن الحضور جميعا. طبعا أنا الدكتور هاني عضو مباركوت، وأنا استشاري أمراض باطنة وعلاجية، خريج جامعة عدن، كلية الطب جامعة عدن، والبوست جرادويت في جامعة أسيوط دكتور زايد، وبالإضافة اليمنية وأيضا ديابيتس